I too am looking forward to that discussion that Dr. Schab just referred to with all of you from the different points of view that you occupy. I would just like to get the ball rolling by congratulating him on a really, I think, quite wonderful paper. A very sort of beguilingly accessible, apparently simple narrative about very complex and very subtle issues, which you introduced wonderfully. So thank you very much for that. Speaking as an old codger, it gives me real sort of pleasure to recognize what the place of a psychoanalytic clinician is in the era that we find ourselves. I think that if this is what they're like, the future is bright. There were two things that really stood out for me in the way that Dr. Schab approached this huge topic in, as I say, such a appealing and inviting way. That struck me as being essentially psychoanalytical attitudes or psychoanalytical approaches. The first was an absence of what has been called the arrogance of the present. I think that that's a deeply psychoanalytical attitude, to not be stuck in the hubris and the fundamentalism of one's own present moment and one's own present time. To see this history of psychiatry perspective, which so throws such profoundly important lights on the way that we see things today, where we don't recognize how ridiculous it's going to look 20 years from now. And that historical attitude, that developmental attitude, that lack of arrogance of the present is, I think, a deeply psychoanalytical attitude. And it may just be, in fact, a subset of the second characteristic that stood out for me, which is a tolerance of complexity. I mean, I think it's very, very much what psychoanalysts are trained to do, which is something, again, deceptively simple, but very difficult to acquire and to nurture. The way in which Dr. Schab introduced what is, as I say, very complicated, very subtle, very difficult questions in a way that just opens them and reveals them and doesn't pretend that they're not there, and illustrates for us the very, very difficult nature of the apparently simple practical decisions that the psychiatric physician has to take. To allow all of that to be in his mind when making clinical decisions is, I think, again, a deeply psychoanalytical attitude. So all of this to say the future is bright, the future is neuropsychoanalytical. And now I'm open the discussion, and I'm going to wander around with this mic. That's Siri Hustvedt, and I'm taking it down to her.
Thank you for the talk. And I want to say that you sidestepped the philosophy a little bit, but what's fascinating to me about this multiple model approach is that in some way you're arguing that the representation determines the percept, so that each language creates its own vision, its own image. And so that's a very late modern idea. And I just wanted you to comment on that. I mean, is there really a possibility of unifying these multiple models if the percept changes with each model?
Gosh, I don't know. All these sciences go through so many rounds of every science goes through round after round after round of models that start to accumulate and then fold and then get replaced and so on and so forth. I think that's possible one day. I think it's possible one day. Let me hazard something a little strange to say, which is that one thing that's always going to make it hard to have a single language about all of this is that, you know, however you think about and however you resolve or don't resolve the mind-body problem, we are always, I think, every one of us, because we're human, drawn to some side of the mind-body problem. And so we're always going to have our own preferences about kind of how we talk about these things. And those preferences won't necessarily be based on resolution of scientific questions or philosophical questions, but just on our own human tendencies to prefer to talk about things in certain kinds of ways. It's unsatisfying.
I'm a clinical social worker, so I'm one of these non-medical psychotherapists.
Say your name.
I'm Denise Zalman from Turner Institute,
Hi.
Alpha University. I'm a clinical social worker, and I utilize the assistance of psychiatrists, just like the psychologists who referred to you. And both my training and the training of the psychiatrists that I interact with, from what I understand, we use only number one and number two. We see the product and we see the facilitation. We have not been trained to interact on the level of the other three factors. So one of the things I wanted to say is that in some ways, if this is a prediction of what the future is going to be, we are talking here about creating a dialogue. Because it seems to me that more and more separation of psychotherapy and psychiatry is going to happen, and that if you are in fact the new brand, the predictor of the new brand, this is going to be a very, very different kind of dialogue than we have had so far.
Well, that's nice, Denise. Can you just say something, maybe give an example of what those conversations that you have with your psychiatrist colleagues sound like?
I have when I do or when I don't. Because usually, I mean, in the many years that I practiced, I finally found a psychiatrist who talks to me. Somebody who would call me and say, you know, I saw the patient, not only this is what I prescribed, but this is what I said, this is what the patient said, and I can then begin to talk about any of those three factors. Whether or not this is going to affect the medication, I'm not so sure, but it does certainly enlighten me as a therapist about how I can use the psychiatrist. What do I talk about? Well, the first two factors are very simple. I would say something along the lines of this patient is depressed, so I would like to have something to reduce the depression or reduce the anxiety. And I would hope the psychiatrist would validate my view on the consultation. The second one, definitely, I have been always trained to see medication only as a facilitator of psychotherapy. In fact, to not call in the psychiatrist until the moment that I realize that the psychotherapy isn't going forward, to delay it as much as I can, rather than as an enhancer.
Yeah.
So the ability to discuss other aspects, the personality aspects, the defensive aspects, would in fact enable both of us to reach out to each other much earlier with a very, very different frame of mind.
I think Denise said it a lot. Yeah. Let's see, where would I begin? I mean, one is I've had that experience too, where I've started working with a new therapist, or social worker, or psychologist, whatever, and the person's shocked that I've called him or her. You know, I think one other, I don't know your colleagues, but you know, just speaking for myself, I also know that just the pressures of time force us to kind of simplify and dramatically pick the most minimalist way of thinking about the patient. and that's too bad. But I think most of us suffer from that. You know, it may also, another problem may also be that if you're working with a psychiatrist who doesn't know you very well, he might be a little bit, and I have this experience, feel a little bit ashamed of all the uncertainties and all the complexities and insecurities about what models he or she thinks psychoanalytic or psychopharmacological, what theories might be relevant here. You know, I certainly know sometimes before I call colleagues who I need as referral sources, I sometimes read through the patient's chart of my notes very carefully before I call back, because I want to make a good impression. And make it clear that I've gotten to know this person and I've had some more sophisticated thoughts about the patient than simply that the patient has a depression with a capital D, or has generalized anxiety disorder or something. There's a lot of forces besides lack of sort of theoretical thinking, I think, that curtail communication between therapists and psychiatrists.
Thank you very much for your talk. It was extremely enlightening. Because I have patients who are borderline and psychotic, and we know that such patients induce enormously powerful feelings, countertransference feelings. And I wonder if you would care to comment on the transference and countertransference implications of the work that you do.
Wow, that's a big question. Let me try to actually answer that question within the confines of what we've already been talking about. Let me pick that patient that I was describing to you, who called Susie. I certainly, I had the feeling, and my colleague, the psychologist, saw her, had both shared this feeling of just want to shake her and tell her, look, you're not getting this boyfriend back. I mean, he made it really clear. But I couldn't tell her that, or I couldn't shake her, certainly. So, what I did tell her actually really didn't employ any of these 5 languages. Maybe what I'm going to describe is a 6th language. I said to her, listen, whether or not you're going to get your boyfriend back, or whether or not you can make that happen, you can't manage the situation. You can't evaluate the possibility. If there is a real possibility, you can't make it happen. If there's not a possibility, you can't let it go, unless you can function a little better. And my thought was at that time that that the salience of this fantasy about the boyfriend, and she actually could consciously renege on that desire. She could say, okay, I'm going to give it up, but then she would just keep pressing me and the psychologist in some way that really indicated a kind of pre-conscious or unconscious fantasy of absolutely having to get this boyfriend back. And so I said to her, look, I don't know if you're going to get him back, and I can't evaluate that, and so on. And I can't, you need to be able to function. And I think that much too much, regardless of how realistic it is, realistic or unrealistic it is, to get this boyfriend back, way too much psychological real estate is being taken up by this fantasy. And the way, and I said, we have drugs that can kind of shrink can shrink their real estate. Then I had the more difficult task of explaining to her that those drugs are antipsychotics. And what I do in these situations is I say, look, these drugs are, this isn't necessarily because you're psychotic. these drugs all do all kinds of things, and for marketing reasons, they get categorized. But a little bit of this drug, I think, might reduce the salience of this desire, and once that's reduced, you could actually get to working on it, either getting rid of it or fulfilling it. She never came back. But not, probably, I don't think because of that. I think because of something else that had happened. Because of something else that had happened. But I may not have. I was treading very carefully not to give her the idea that I was going to make the same mistake. It wasn't a mistake. It just but that I wasn't going to do the same thing the prior psychiatrist did, which was to which was to indicate that she was going to have to get over this boyfriend.
Here comes Maggie Zollner.
Thank you, David. So there's so many things that we could all say and elaborate on in terms of thinking about the underlying brain processes, but I just mainly wanted to say a sort of a cultural and emotional comment. So I had invited David because I collaborate with him. When I need to refer someone for medication, I usually call David, because as you can see, it's so satisfying to have a psychiatrist, sometimes evaluate the patient and say, I don't think this person needs medication. Or to have a psychodynamically informed hypothesis about what kind of medication might be helpful as the first try. And I think you showed us, how much of your sensitivity goes into that. But I think also this dialogue is important, at least on one level, in terms of the whole issue of idealization and fetishization of medication. And then also for us non-medical analysts, there's sort of an idealization of anybody with an MD behind their name. So that sometimes I feel affected by the whole ideology of the culture, where sometimes the patient is in a difficult place and I just have that rescue fantasy. I'm just going to send him to David, and David will give him something, and then this will all be fixed. And so as I was hearing you talk today, and especially the last bit that you did, which was so cool, and we could have like a whole day of thinking about different kind of patients and sort of going through those different systems and speculating about what's happening and everything. But to appreciate the complexity of what you go through as you're trying to make that determination, that's part of the idealization I think that we need to go through. And also I was thinking about when I heard Jonathan Shedler speak last month, and he wrote a very important paper that everyone in the room should read called The Efficacy of Psychodynamic Therapy. It came out in 2010, where he did a meta-analysis of outcome studies on psychodynamic therapy. And the graph that he shows is really impressive. There are these strong effect sizes for psychodynamic therapy and for other kinds of talk therapy, and they're much stronger than the effect size for medication. And then also in terms of the proportion of patients that medication helps, that we should all realize that it's only a third of patients who get some kind of significant symptom reduction. So I just wanted to add to that that's an important part of this dialogue, is that as a field, as a species, we're still very much trying to figure out how all of this works, and that medication is not the be-all and the end-all, but we're at the beginning of that process. So thank you.
Yeah, thanks. Becky Chaplin has had her hand up.
Oh,
Yeah.
I'm sorry.
No, it's okay. No.
I've been instructed otherwise.
Yeah, that's okay. No.
I just have a quick comment to add
Sure.
to what Maggie's saying,
Yeah.
what you were saying before about choosing, thinking about choosing an antipsychotic for your patient. That I'm a prescriber, and I have a lot of, as I think you do, ideas and speculations and fantasies about what these drugs may do. And I dream of the day when we have some confirming evidence and where we would actually have some way to measure whether indeed starting a patient like your patient who fits that kind of diagnostic profile, whether in fact she does benefit from being on an antipsychotic. Because as far as I'm aware, the evidence is not,
Right.
there's not a lot of it, and it's not very satisfactory.
Right. That's right.
It's a compelling idea.
Absolutely.
But we need
Totally agree. Yeah.
some controlled studies.
Sure.
Lots lots of questions, but I did promise this. And then you, yes, I haven't forgotten to do that. And then it's Henry.
Fascinating. I've been interested in this topic of the integration of psychotherapy, or experiential therapies and medication since my residency, which began in '72, and I've been taught courses on it, taught my residents about it. But what I realized in listening to you is I also, like the person across the aisle, only thought of the first two languages and models and not the other three, and I think that greatly expands and deepens the way of thinking and talking, both with colleagues, students, and patients. I had questions, as a prescriber also, I had questions about two of the things you mentioned in thinking about the patient. One, because they're addictive, depressants, and impulse facilitating, like their cousins alcohol, I have virtually none, most of what I do is therapy. I only, for the time reason, I only work with about 5 non-physician therapists, because otherwise I wouldn't be able to speak with them enough, I think. Sure. And most of my time and income is therapy. But virtually none of my patients are on daily benzos because of those reasons. And the fourth reason is I think they're anti-insightful, because they, like alcohol is anti-insightful, and they give the message that there's no meaning to your anxiety, and there's no way to deal with it other than an alcohol-like chemical. So I wonder what your thoughts are about that, because literally I function fine, neither for sleep nor for anxiety do I have any of my patients over the years on benzos. The other thought I had about the antipsychotics, I thought that was very interesting in terms of sort of firming the boundaries between conceptual categories. I've come to think in the past few years of them as, and I explain, because they often, in a tiny dose, as we know for years, even with the first generation antipsychotics, help people who are terribly depressed. And I've come to think of them as cognitive medicines, in the sense that I think they gear down the volume of self-hating thoughts, and maybe, and self-negating and self-dismissing thoughts, and maybe that's how, another way in which they help people who are terribly depressed. And that's how I refer to them. I say they're marketed as antipsychotics, but I think they do something to thinking, because there are many, I have several non-psychotic patients who are doing remarkably well with just a tiny dose.
Yeah, and that's what I was thinking of in the case of the smoke. It's like a tiny nighttime dose that would also help with their sleep.
Right.
Yeah, that's true. Do you think though that their effect on thinking is so surgically precise, as you're saying there, that they narrowly target self-hating, self-directed?
No, I don't think it's that precise. What I say to my patients about all the medicines is we have lots of theories, but very little knowledge. And I say, we don't know in general really how they work, and I don't know whether and how it may work for you. So no, I don't think that that's surgically precise.
Right.
But I also wonder what your thoughts are, because benzodiazepines in our society are passed out like M&Ms, and I think that's really very unhelpful. I wonder what your thoughts are about benzos.
Well, let me address the question, the point you made about benzodiazepines interfering with therapy. That has been studied with cognitive behavioral therapy. I don't remember if this was for treatment of anxiety disorders or depression, but there has been a finding several times that benzodiazepines interfere with either the immediate effect of cognitive behavioral therapy or the degree to which it takes and persists, so that its benefits persist and take hold over the long term. As far as a more general question about benzodiazepines, what can I say in summary about them? Well, one is I don't think that they're all alike. I really think that they're actually quite different. First of all, some of them, the major difference is there's two differences I think among them. One has to do with the ratio to which they are sedating versus anxiety relieving. So Xanax, for example, alprazolam, appears to be the most, it's sort of anxiolysis to sedation ratio seems to be highest, as far as I can tell. That's one issue. The other is there are every psychiatrist knows people like this, and there are clearly people who can take the same dose for years and years and years and years, and they never need to escalate the dose, and they're fine with it. It's just hard to know who those people are going to be. I don't know how to predict that. And then another problem, another issue is that there are also clearly some conditions where they definitely just keep working, like in panic disorder, like long-acting alprazolam, Xanax XR, has, as far as anybody can tell, persisting indefinite benefit in panic disorder. People don't need to keep raising the doses and so on and so forth with it. But, you know, they, I think they affect people's mood and not always very well. And so that's a problem. Xanax was because it has a tricyclic structure, was in the old days said to be antidepressant. And in fact, in Japan, until around 2000, they didn't have any SSRIs because they treated depression with benzodiazepines. So I've read. So, yeah, but there's clearly people who just need more and more of them, and I also think because they, you know, like alcohol, they can give you the impression of sleep, but they interfere with sleep architecture, and so and sometimes it's just enough to give the person an impression of sleep. The person wakes up at 7 thinking he slept well and doesn't feel so demoralized about a bad night. So, God, it's complicated. You're raising great questions. Yeah.
Next question, Sharon.
Yeah.
Hi, I'm Barbara Bartlett, a psychiatrist from Manhattan. I really enjoyed your talk, especially your presentation of Cloninger's work. And what interested me was that the way Cloninger pointed out that people who are novelty seeking need more dopamine, and that pertains to people with sex addictions, attention deficit disorder, addictions in general. And in the sex addiction community, there's a controversy raging about whether these people need serotonergic or dopaminergic medication, but I wonder where you stand on it. I mean, I feel that they need dopaminergics, and often my sex addicts are, you know, they're low in testosterone, which is related to a deficiency in dopamine, and they respond well to dopaminergic medications and nutritional supplements like tyrosine and B vitamins. So, would you have an opinion about whether sex addicts are, you know, need more dopamine or more serotonin?
That's a great question. Well, one problem is a kind of more of a kind of biochemical and neurochemical problem, which is that, you know, there's two reasons that SSRIs affect sexual functioning. I'm just bringing this up as background to explain, to try to answer your question. Pathways from the midbrain raphe nuclei that go into the spinal cord reduce ejaculation and orgasm, and pathways from the midbrain raphe nucleus that go into I think the basal ganglia and nigrostriatal pathways cause loss of libido, and this is because apparently there's some sort of balance between serotonin and dopamine that's maintained in that region of the brain, and that these levels are antagonistic to each other. So SSRIs might raise serotonin and therefore, unfortunately, depress dopamine levels. I say all this just to say that if you believe in that reasoning, it can't be right that both dopamine and serotonin could be good for sex addiction because they're antagonistic to each other, at least in that important region of the brain. I've never had a patient with clear sex addiction, or if he had it or she had it, it wasn't a problem to him or her. but I have had two patients with kind of internet porn addictions, and I didn't know how to treat that. And I went and did some reading and talked to colleagues, and it's one of these conditions like migraine headache. If you look at a neurology textbook under how to treat migraine, there's a list of 30 drugs, and which means that no one of them really works very well. You just have to try one after another. Well, that's what I found when I went to look up what drugs might help with sex addiction. But I did try these two patients stimulants, which are dopamine drugs. One person got a really great response, and one person got a middling response. I don't know what to make of that N of 2.
The next question is Henry Canada.
I also found this to be a very, very interesting presentation, and it's supposed to be clinically oriented, but it obviously has raised many theoretical points. And one of the things that we have to remember that clinicians, no matter what the degree is, whether it's in psychology, social work, medicine, whatever, clinicians are under pressure all the time. We have to make decisions based on imperfect information. And so we're pressed, and we have to do things, as I said, without the luxury of a long laboratory trial and imperfect information. Fortunately, the work we do does not get submitted to journals and criticized in that way, so we get away with it. And with regard to meditations, one of the there is so much knowledge in terms of the neurotransmitters and the receptors for the reuptake of the neurotransmitters, and it's wonderful, but we really don't know how to apply that clinically, because as we mentioned, the efficacy of these things, whether whichever medication you want, is certainly not 100%. But the efficacy of the psychotherapies, it's not 100%. And I wonder, one of the things that has not been mentioned, and it was not included as part of the talk, but I wonder if you could comment on this. When people are criticizing medication, they talk about the placebo effect as if this somehow negates the efficacy of medication. There is a placebo effect in using medication. There's a placebo effect in psychotherapy, and everyone somehow seems to dislike it, to criticize it. The placebo effect in psychotherapy used to be called a positive transference, that it's not real, it doesn't really count, and the same way with meditation. I wonder if you would comment on, there must be some similarity, some connection. I wonder if it's appropriate to comment on that.
This is my father-in-law, but at the stump me. How to comment on that? Well, first you're bringing up the broad question of specificity of effects and what the active ingredients are, both in psychotherapy and in medication treatment. This whole placebo thing has, I was very extremely sympathetic to all the placebo research that's been coming out, and all the criticism of the medications and so on, in terms of their effectiveness and so on and so forth. I think my sort of own kind of iconoclastic way of thinking about these things makes me inclined to kind of be anti-medication in that way, or at least anti-big pharma. But I've come more and more to appreciate something about placebo effect that I didn't really know enough about before, and that's the whole nocebo effect issue. So when patients are randomized in these clinical trials into an active arm and where they're given medication, or a placebo arm where they're given placebo, and they don't know which they are, they have certain kinds of expectations about what they're being given. Now, on the one hand, the pharmaceutical companies a number of years ago pretty much stopped testing the blind in pharmaceutical trials. So, if you randomize, if you're put on either medication or placebo, you're not supposed to know which one you're getting. But the pharmaceutical companies were finding something very embarrassing, which was that people could figure out very quickly, usually on the basis of side effects, whether they were getting active medication or placebo. And because of that embarrassing factor, they stopped testing the testing the blind, where they would ask people, what do you think you're getting? And they stopped doing that, or at least they stopped reporting it in their trials. But that factor, the sort of whereby people were figuring out what they were getting, really would inflate the seeming effectiveness of the medications, because people who knew they were getting real medication would do well, and people who were getting placebo would be discouraged. But there's a kind of an opposite problem as well, which is that when you randomize people to getting medication or placebo and they don't know what they're getting, if they think there's a 50% chance that they're not getting a real drug, that actually hurts their chances of responding to the medication. So that's a major factor that causes the effect of antidepressants to be underestimated, probably in clinical trials. My colleague Brett Rutherford at Columbia is doing with Steve Roos a very, very interesting study in which they're randomizing people to different fractions of percentages of how much of whether they're going to get medication or placebo. So one group of people would be told you have a 50% chance of getting medication or placebo. Another group of people would be told you have a 25% chance of getting medication and a 75% chance of getting placebo. And another group would be told there's a 75% chance of getting medication and only a 25% chance that you're getting placebo. And the idea here is to to demonstrate that people's expectations about the likelihood that they're getting real medication or placebo may be drastically affecting their responses. I used to think that clinicians were fooling themselves when they would say, oh, medications work so well in my practice. I don't know what it is all about this placebo stuff and all these meta-analyses that say medications don't work and so on and so forth. And I thought that my colleagues and then I myself were just being sort of fooled by our own sort of self-efficacy biases. But people do better getting medication in an office with a doctor, their own private doctor, than they do in a clinical trial. Partly because of this issue I've told you about, namely that in the doctor's office they know they're getting real medication, so they're not getting the nocebo effect, namely the concern that they're giving a placebo. But additionally, there's a certain kind of cheerleading that you can do in your office that you don't typically do in a clinical trial if you've ever worked in one. And when a patient comes to me and says, I'm only being sort of partly flippant here, but when a patient says to me, oh, I'm having side effects and so on and so forth, I say, good. That means that this medication is not working like some inert agent in you. It's not just passing through your body kind of unattended. Your body's having to respond to it. It's only certain patients I would say that to, and I do so in a softened way. But I try to convey that sentiment to them, and so you can kind of cheerlead a little bit, in a way, and get better responses.
Next question's at the back.
Yeah.
I'm Barry Rand. I'm a prescribing psychoanalyst, and I teach a course at IPE at NYU on medication and psychoanalysis. And actually what we teach is what you have put on the side, which is the meanings of medication and the meaning of the pharmacological experience. So I was a little concerned about your 5 different ways of thinking about medications. They all seem to be ways that a biological agent could impact on one's psychology. And it seems to me that medication is not a biological agent. Medication is a biopsychosocial agent, the way we used to talk about it in psychiatry. And most patients don't get medication just by taking a biological agent. They have an experience, what we were talking about, a pharmacological experience, and it involves either the prescribing psychoanalyst, psychotherapist, or a team, split treatment. And someone said that medication kind of fosters meaninglessness. I think it does the opposite. Del Tutter talks about how meaningful medication is, and not just the medication, but the prescriber and the psychoanalyst, etc. So when what I teach is that we have to look at the transference and countertransference elements right from the moment that the therapist is thinking about setting for a referral or prescribing medication, and that and looking at the whole process. And so we may be affecting these biological pathways in the way that you're talking about, but through this full experience. And we, as prescribers, have fantasies about the medications. Sometimes we call them scientific ideas, but sometimes there are our own fantasies about how the medications are going to work, and the fantasies of the patient in response to it. And that whole paradigm then gets expressed in prescribing the medication, taking it, etc. And so, you know, these activating or sedating medications, you can give a paranoid patient a sedating medication and they're activated by it because of their psychological responses to it. So I think I just want to broaden the issue to looking at medication from this perspective and ask what you think about it.
Well, you know, I agree with you 100%, Barry. This is not an either-or issue. I had particularly carved out the effects of medications, kind of biological, chemical effects of medications on the mind, because there is already so much great, fascinating literature, like the paper by Del Tutter that you mentioned, addressing the bigger meanings. And Maggie Zellner was touching on this when she said how she gets this feeling inside of wanting to kind of save the patient. Just that very, very, very moment that you first think that the patient might need medication is very, 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 very meaningful. There's a great book by Larry Sandberg and Fred Bush. It's called Integrating Psychotherapy and Medication or something. That's a great sort of 2 or 3 hour read. It's really just wonderfully written, and it addresses all these kinds of things. And there's an article by Del Tutter, and there's a lot of wonderful literature on those kinds of problems that you're talking about, and that are actually much on a day-to-day basis are probably more consuming than the kinds of things that I'm talking about. So yeah, thanks for making that point there.
Hi, I'm a neurologist, so I have a slightly different perspective on some of the things.
Sorry.
One of them is that medications generally introduced don't necessarily have the same effect a week or 2 later or a few months later because of adaptive plasticity. As you know, receptor changes occur, and essentially the brain finds a way to go back to essentially its prior state to a large degree. Largely demonstrated by the fact that when you try to remove these medications, patients seem to feel that they absolutely need to go back on the medication to come back to their prior sort of equilibrium point.
Right.
Suggesting that there may be more problems with the prescription of these medications than we realize. Because
Absolutely.
we're introducing a permanent standard of behavior in the form of a pill. Now, rather than, say, an existential questioning of the circumstances that brought them to the psychiatrist and the analyst to begin with. I don't know if you would comment on that.
No, I think that's an important issue, that medications, that a discrete period on a particular medication can still probably have lasting effects. One place where I see this sometimes described is, and somehow and yet ignored, is around the issue of benzodiazepines. That say your name once more. Dan was talking about. There's this anti-anxiety drug, Buspar, and it's said that people who have been on benzodiazepines at some point don't get any response to that medication, or get very minimal response to that, which to me means that a person's exposure to benzodiazepine has actually permanently changed their brain and made them no longer able to respond to that medication. So I think that's probably a real concern. Another way that this might be a factor is that there's some people who think that mood cycling is actually that the pattern of mood cycling, not so much the expression, but that the pattern of mood cycling for any particular person is somewhat already genetically or epigenetically encoded, so that things like mood stabilizers really actually just slow down one's passage through a pre-programmed pattern of, say, depression, mania, euthymia, depression, euthymia, depression, etc. And all you're doing is really is kind of stretching out a pre-programmed pattern. And if that's true, then when, for example, if we put a person on an antidepressant and say that who has maybe an occult bipolar disorder and have that person sort of cycle through that pattern a little faster, we've actually moved them, and they stop the medication. We have nevertheless possibly have moved them farther along in that kind of cycling pattern to a kind of a further point on that map. And that's probably a bad thing, because bipolar disorders tend to get worse, not better. And so, if you simply, I think, does that make sense? A little bit.
Can you manage two more questions?
Sure, because Larry, yeah, absolutely.
You've had your hand up a lot.
I did, thank you.
Thank you.
Not a clinician, so I'd like to ask a
Great.
non-technical question. Everybody self-medicates. People take booze and they smoke cigarettes, and
Sure.
the average American drinks 3 cups of coffee a day, and now we have something called Tom Wonderful, which I have no idea what that is, but it seems to be good for you. So the question is, using your 5 categories of language, what do you think is really happening? If you ask people why they do it, they say it feels good, makes me, stay awake or whatever, but what's really happening?
Wow.
I'm not the father-in-law, I put it in asking you the question.
Yeah, right. What do I think is really happening? Well, there are some people who self-medicate very successfully. There are people who drink 1 or 2 martinis at 5 o'clock every evening for 40, 50 years, and it really seems to help them and doesn't progress into anything worse. And there are some people who, drink. My father drinks black coffee before he goes to sleep, and he sleeps well all the time. What do I think is happening? Can anybody else try to answer that? Yeah.
These are powerful drugs and useful drugs. If nicotine tried to get put on the market today, it wouldn't be able to pass the test.
So we're going to close with a question from a philosophical, psychoanalytical perspective.
This is another kind of question about the language you use with your patients. You describe you and Susie, and you're using the word salient with her. You describe your relationship with Susie as you're using the word salient with her about the boyfriend. I would think that would be a word that might lend or tend to kind of intellectualization. Do you have an experience that?
Yes. Yes, and I think there's a role for intellectualization when talking to people. I mean, I need to find a kind of a diffused way of speaking with her. I don't know if I use that word specifically. That concept of salience, I think, comes from a paper by Schab, who's a Canadian psychiatrist, who talks about dopamine as something that adds salience, adds sort of importance to whatever one's attending to. I think you're right that it's intellectualizing. And I think also because this patient kind of scared me, that I was responding a little bit to that. My fear was making me kind of start talking to her in a little bit of a distant way, probably. She frightened me. So I think you're right. Yeah.
So we must close, and I would like to propose a few things. First of all, a big thanks. As you can see, Dr. Schab, we could easily carry on for another hour of discussion, and that's testimony to the rich and fruitful food for thought that you gave us. I'd like to say two more things. The one is in going back to my opening comments about the arrogance of the present and the importance of taking a historical perspective and so on. There was a wonderful phrase in Vienna in Freud's day, which I think is particularly apt in the light of all of this, which went in English, in the past, even the future was better. And the last is just to remind you again that on the 4th of February we have Rodolfo Linas here. Thanks for coming, and thank you so much, Dr. Schab.